change lives, not only saving lives, but it changed lives in many ways, more than one. And this change, after the discovery of insulin, which was initially collected from subhuman species, whose structures are very close to the normal human insulin and therefore were amenable to uses. But we found over the years that it suffers from some limitations, and like in every aspect of medicine, strive to achieve perfection so far as insulin continues even till death. So starting with the animal insulin and then we shifting to the recombinant human insulin, but the journey did not stop there, because we have understood that even so to say, the normal human insulin developed genetically, recombinant technology, suffers from some limitations. So are you not happy with the insulin that you use, the normal recombinant DNA technology insulin? Well, I just would like to recall this simple fact that the way that you use insulin is not really physiological. We'll try to mimic physiology so far as endocrinology is concerned. Endocrinology that way is very simple. So to say, if you have got a deficient disease, you replace it in a physiological manner. If you have got an excess disease, you just either extirpate or suppress that hormone. So in diabetes, where there is a functional deficiency of insulin, be it numerically in type 1 or functionally in type 2, we try to replace insulin in such situation, but that has to be done in a physiological manner. However intelligent you are, however technologically prowess that you have, the fact remains that insulin cannot be delivered in the way it should be. We remember that insulin is secreted in the portal circulation, and the current technology does not support the supply of insulin that way. So we are trying to make do with subcutaneous or intravenous or some other methodology. That actually changes the pharmacodynamics and the pharmacokinetics of the insulin, and there lies the problem. And so whatever you do, whatever way you deliver insulin, it will suffer from some limitations. And we know that insulin is secreted in two different fashions. One is basal secretion and another is mill-related or prandial secretion. And that is why you need to have two different types of insulin, which gives you or mimics the basal insulin secretion, and the one which lasts for a shorter period of time related to the mill is a prandial insulin secretion. So what is the problem with the basal insulin that we have in our hand right now? To put it in short, they are not as long as it should be and not as short as should be. So it suffers from the limitation that most of the insulin, the basal insulin that you use, they are less than 24 hours of duration. So many times probably you need to take 2 shots, so that is increasing the discomfort. They decrease the flexibility. The absorption in the subcutaneous tissue is variable because of very many reasons. And whatever you do, once you put insulin into the subcutaneous tissue, the amount of insulin initially is high and later on it decreases, and therefore it has got the property of having, so to say, a peak. So a basal insulin ideally should not have a peak. It has to be a peakless insulin. So it definitely suffers from the limitation of having a peak, however small it might be. And when you use insulin, basal insulin, especially given at night to mimic the insulin secretory pattern from the pancreas to suppress the nighttime hepatic glucose output, it of course is packaged with the problem of giving rise to nocturnal hypoglycemia, which is difficult to appreciate and difficult to treat. And obviously, we know that insulin is associated with increase in the weight gain, which is an independent risk factor for cardiovascular disease and various other factors. What are the problems with the prandial insulin? Similarly, the prandial insulins are long, as long we do not want it to be, and it is not as short we want to satisfy our demand. So it starts late and ends late, which we do not like. So we need to have insulin which starts immediately after food, which is difficult to mimic, and should stop its function within 1.5 to 2 hours, which it does not. It surpasses that and therefore leads to postprandial hypoglycemia as well. And to prevent that, we need to have defensive eating, and that defensive eating leads to weight gain and compounds the problem of obesity. So, is there any way that we can probably circumvent all this and try to reach so to say, our dream insulin, which is very close to normalcy in the sense, a physiological sense? I mean, an ideal basal insulin should be something like this, peakless. The fast-acting insulin, the prandial insulin, should be rising very fast and going down quickly. Unfortunately, this is the reality and this is the ideal situation. So can we go from here to there? Let's take a quick peek into the situation as we have right now. So that talks about the need to change the insulin molecule so that it serves the purpose that you need to have. We also need to consider another important factor which is coming up in the recent relevance in the scientific parlance, which is known as glycemic variability. To put it in short, in a normal person, the glucose varies throughout the day, maybe something like this. This is the postprandial state, this is the fasting or preprandial state. Now, unfortunately, and obviously, this is how ideally a person's glycemic variability should be when we are treating a person with dysglycemia. But unfortunately, because of the limitations of the insulin and the pathological state, the glucose varies widely. Now, the funny part is, if we measure the average of glucose by whatever means, you will see the average remains something like this in both the situations, both in this as well as in this. And I must remind you at this point of time that you, me and everybody harps on the average glycemic control parameters like glycated hemoglobin, which is dependent on the average. So it is very much possible that a person with a glycated hemoglobin in the desirable zone of say 7, but at the same point may have a lot of ups and downs. And this ups and downs is an independent risk factor for various problems including cardiovascular disease. So despite having the similar level of average glycemia, the two different persons with diabetes may behave differently simply because of this glycemic variability. And usage of insulin is intimately associated with this problem. So can we circumvent this one? So the insulin that we have been using for such a long period of time since the invention of it, suffers from this limitation of giving this wide glycemic variability. So we really need to have an insulin which reduces this glycemic variability. Now, can you really find out who is faring poorly so far as this glycemic variability or especially the sugar going down at night? Of course, we can measure by the continuous glucose measurement, but that's not a practical one for everyday use. There is a surrogate measure of it, like variability of fasting glucose. If we measure a fasting glucose for consecutive days for say 20 days, and if we see the variability, the persons who have got a wider variability of the fasting glucose are the ones who are having a increased incidence of nocturnal hypoglycemia, followed by fasting hyperglycemia, which is known as Somogyi phenomenon. So people who are having a increased fasting sugar variability are the ones who are at risk. So this increasing variability or glycemic variability is an independent risk factor for not only mortality, not only major adverse cardiovascular events, but also various other complications of diabetes that brings with time. Now, our old friend, the changed insulin, the first, so to say, the changed insulin was neutral protamine hagedorn, that is NPH insulin, discovered quite long ago, we have been using it for pretty long time, and serves as a reasonable surrogate for basal insulin delivery, but many times probably we'll have to give twice daily. This suffers from this problem of increased glucose variability and does not serve the purpose of having a, so to say, a peakless insulin being delivered as a basal insulin. And there come the new kid in the block, the insulin degludec, which when compared with the NPH head-on had shown that there is definitely a wide bit of difference so far as the glycemic variability is concerned. When you are trying to achieve a good sugar control, tight sugar control, the NPH gives a higher incidence of hypoglycemia compared to insulin degludec. So, hypoglycemia or recurrent hypoglycemia or hypoglycemia awareness especially is the situation where probably we will have to fall back on and derive the benefits out of this newer insulin, which gives you a benefit of good glycemic control but less of nocturnal hypoglycemia. Hypoglycemia, I mean, of course, there are problems associated with the hypoglycemia in the biological sense, such as the increased cardiovascular disease. It also has got different ramifications or wider ramifications in the sense that it has comes with a large socioeconomic consequences. It is not only the direct costs, but also indirect costs, which many times we do not really take into account, has got an important implication so far as the quality of life or QOL of every patient is concerned. To address this problem, probably it is justified to use those special insulins which gives you a less incidence of nocturnal hypoglycemia or less glycemic variability because of its structural difference. So there was an important study done and which had thrown a good deal of evidence base so far as this incidence of hypoglycemia with the standard insulin vis-a-vis the newer insulin. And the interesting aspect is that it is a switchover trial, which is probably one of the strongest mode of evidence base. And in that particular study, when it has been compared with the standard of care like glargine, which has established itself as a good basal insulin, and when it is compared with the changed or newer insulin like degludec, had shown even in this not only parallel but crossover trial shown that it does have a bit of an edge compared to the standard. So how does this degludec and this basal insulin glargine fare against each other? Well, they are reasonably good in reducing the glycated hemoglobin. Both are pretty good in that, especially controlling the fasting hyperglycemia. They both have got significant effect. But there is a minor degree of difference amongst the two, that the incidence of nocturnal hypoglycemia is slightly less with degludec compared to glargine. And this glargine that we are talking about is the U100 glargine that has been the standard practice for the last so many years, more than a decade. The one which has come recently, the U300 glargine, is probably different and closer to the pharmacokinetics of degludec. So the severe hypoglycemia is also less, especially in type 1 diabetes. And this U300 glargine, which is biochemically same as the standard glargine, U100 glargine, and this U300, which is 3 times concentrated, has got a different property of absorption in the subcutaneous tissue, and thereby it has got a flatter profile, that is almost not having a peak. So it goes closer to our heart. And if we compare degludec versus glargine U300, we will see that there is a minor degree of difference, probably nothing much to choose between, but even then there is some degree of less dose advantage in degludec, slightly less nocturnal hypoglycemia even with degludec. And another advantage of degludec compared to the other basal insulin is that it has got a flexible timing of administration. It can be given, today it can be given in the morning, tomorrow it can be given in the evening, day after tomorrow maybe in the night, simply because of its effect lasts longer than 24 hours. Similarly, there are other insulins like insulin aspart, which is bolus insulin, which is ultra fast in the sense that it starts its action pretty fast and ends its action pretty fast, in the sense that it serves only during the prandial phase, thereby not allowing the glucose to go pretty high. And here once again, it gives you or derives the benefit of less hypoglycemia. I would skip for some slides for the sake of time, for the brevity, and we will probably go quickly to another very important aspect of having the sort of deriving the best of both worlds, in the sense that can we have in the same pen an insulin and GLP-1 analog. GLP-1 analog has established its footprint in the field of diabetology some time ago and established itself as the number one agent to be used in people who have got significant degree of cardiovascular disease. In fact, it's supposed to be taken as the number one agent, surpassing even the metformin, our good old friend, established one. And if we want to get the advantage of that, along with insulin, if in the same pen we can have now, which is coming up recently and had shown a large benefit so far as this is the one combined, and we can see that there is a significant degree of glycemic control, good glycemic control with less amount of weight gain and in fact weight loss with that one. Very minimal increase in hypoglycemia. So that's definitely an advantage. So this dual approach to diabetes, giving a basal insulin and a GLP-1 analog in the single shot, is the talk of the day. We of course would like to give insulin shots as scarcely as is possible. I mean, today probably we can think of giving 1 shot a day. Maybe maybe 2 shots in 3 days even in some situations, but we are probably following to get this one, which can be given once a week, and this derives the benefit of giving less amount of shots. We of course have in our dreams some insulin, the same insulin packaged in such a way that it can be given in an oral form, thereby not only it is obviating the need for injections, but it is being delivered into the portal circulation directly, so it is much more physiological. So it's not only we are taking the option of shots, but also being delivered much more physiologically. It's still in the offing and probably will see the light of the day in a couple of years. We can also think of special insulins, injectable of course, which is smart insulin in the sense that it has got a sensor built in itself and serves its function only when the glucose level in the blood is high. So you can inject it and allow it to act only when the glucose is going high. That's also known as smart insulin. It's still in phase 2 and phase 3 clinical trial, and will see the light of the day surely. We are all worried about using medications, including insulin, in some special population who are underprivileged in the sense that they have got either chronic kidney disease or liver disease, or children or elderly, where these established ones like Degludec and others have established their safety in all these situations, and you can probably use all of them with safety in pregnancy, in elderly, in children. So the relevance of this newer insulin, that it mimics to a large extent, though not perfectly, to the physiological insulin secretion. They have got a property of less amount of hypoglycemia. Cost, of course, would be definitely an impediment, but with time I'm sure the cost is going to come down, and with the usage as well. And oral insulin and smart insulin is the talk of the day. Thank you very much.
Thank you, Dr. Kaushik Pandit, for your nice deliberation. I think long-acting analog and short-acting analog in the same syringe.
Yeah, that's a co-formulation. I mean, in contrast to the premix that we have, that's a mixture, that's a co-formulation. That also is available. There is one formulation which is available which can be given once or twice daily and can serve the purpose of controlling a hyperglycemia in the main meal. Yeah.
And the glycemic variability is well addressed.
Yes, sir.
That is an important point by the injection Degludec in particular.
Yes, sir.
And the ultra-fast acting insulin, that is the aspart, that we are now very much thinking about the 1 hour post-meal glucose surge. So that is well addressed by the ultra-fast acting insulin, because it has correlation of the cardiovascular outcome.
Sure, sir.
So his topic is now open for interaction. Professor Arun Mojumdar.
Coming to the practical situation, actually, majority of diabetics, Indian, they are in the rural side, so the financial capacity is sometimes is not allowing them to use this insulin analogs. So we are still dependent on the conventional insulin to a certain extent. And in our experience, we have found that nocturnal glargine with standard human insulin, non-analog, in the daytime, perhaps is cost effective. Have you got any experience on that? Because many of our patients are getting that stream, that regime. So have you got any comments on that?
If we think of our primary responsibility as a physician of controlling glucose in a majority, we will have to fall back on the standard procedure. The ones who are having special problems like increased incidence of hypoglycemia would need a special approach. Ones who can afford to have medications which is likely to give less hypoglycemia, they can take it out of their pocket. But if we have to think of the masses, if you have to derive the maximum amount of benefit being delivered to the masses, we definitely have to fall back on the standard human insulin that you have been using for quite so many decades.
Another very short comment. We are talking about prandial, we are talking about postprandial. But sometimes we have found that interprandial, at particularly late hours in the evening, sometimes very difficult to control, even with your this sort of all these regimes.
Absolutely. So I think absolutely. The evening rise becomes a major problem to deal with, especially in type 1, it becomes a very difficult problem to deal with. True. And many times they probably need to have one extra shot at that point of time, however difficult or things like that you assume. Yes, sir.
So, this is the last question because we can't invite because of the paucity of time.
Okay. Kaushik, as erudite as ever, I have a very small query kind of thing. We have been talking about Degludec and Glargine I300 as well. Now we have different trials made by both the companies and they show kind of different advantages and disadvantages. That kind of perplexed all of the clinicians. Now, My query is, when we talk about BRIGHT study, they have put emphasis on initiation part of the therapy, as you know very well. Now, what is your take from that? Do you think that this is really a very, very important part in the entire spectrum of treatment of diabetes as far as insulin, basal insulin is concerned?
It has been a standard practice or standard knowledge. The usage of insulin as early as possible derives a lot of benefit. Because we have to understand that insulin is physiological. Insulin is the thing that we really need to give. Whether you are giving an insulinotropic agent in the form of tablets, you actually are giving insulin in a different form. And when you are giving an oral medication, it comes with, obviously, because of its chemical structure, some problems which is difficult to handle and many times difficult to measure as well, the side effects. So if we have to use insulin and insulin early, especially in a situation when you are trying to supplement insulin, it has to be a basal insulin. Because it's the basal insulin secretion which is taken care of in the initial part of the treatment. And there, of course, any basal insulin would serve the purpose, but the ones who are having a significant degree of less amount of hypoglycemia, especially the nocturnal ones, are the Glargine U300 and Degludec. But surely, even our good old friend of NPH insulin serves the purpose at the initial stages. And when they are neither having the hypoglycemia unawareness or the brittleness that is associated with diabetes in the later phase of life.
Okay, we cannot invite any more question. The bottom line is that when a patient is controlled by the age-old insulin without any complication, as he already alluded, then we can jolly well carry on the old insulin. But when there is complications, when there is glycemic variability, when there is hypoglycemia, nocturnal, weight gain, and cardiovascular diseases are gaining ground, then we will have to think of the analog. And regarding analog, he has detailed about everything. So thank you, Dr.
Thank you very much, sir.
For your good delivery.
The speaker, please receive your memento from the chairperson, please. The chairperson will hand over the memento to the speaker, Dr. Pandit. And Dr. UC Ghosh will hand over the memento to the chairperson, Dr. Ashish Basu.